You have to take a step back and look at the full impact that violence has within a healthcare organization. Employee satisfaction, both their perceived and actual safety, the potential impact to quality of patient care, as well as a financial impact. When they look at all of those things together, I think they realize that the cost of inaction is starting to outweigh the cost of, well, we hope things just get better.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Littrell. I'm the Associate Editor of Medical Economics, and I'd like to thank you for joining us today. Before we get started, just a quick note, Physicians Practice will be hosting Practice Academy's new practice management track on Thursday, March 19th. The virtual learning experience is designed for physicians and practice administrators looking for practical, real-world strategies to strengthen operations, improve performance, and build more resilient practices. Speakers include Anders Gilberg of MGMA, Bronson Cox of Encoda, Justin Lamb of Coolblue VA, and Mark Herzog of Veradigm. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. That said, in today's episode, I sat down with Andrea Greco, the Senior Vice President of Healthcare Safety at CENTEGIX. We talked about the findings from CENTEGIX's 2026 Healthcare Trends Report, which makes the case that workplace violence has moved from a security concern to a core driver of staffing instability, regulatory exposure, and financial performance. Andrea explains what practice leaders should take from the data, including why duress alerts now spike at nearly 300% during a narrow window of the morning, and why hallways and exam rooms remain the most dangerous spaces in a care setting. Andrea, thank you for joining us, and now let's get into the episode. Thank you so much for joining us today.
Yeah, thanks for having me. Looking forward to our conversation.
Today we're going to be talking a bit about CENTEGIX's annual Healthcare Trends Report for 2026, which was released at the end of 2025. I guess just to kind of jump into it, the report makes it pretty clear that workplace violence is a major financial and operational risk and a core driver of workplace instability, obviously. 61% of nurses in the report said that they plan to leave their job within the next 12 months. For practices, from a practice angle, how should safety planning evolve when violence is treated as, not just a security issue, but as a risk to business?
Well, I think that to understand that, you have to take a step back and look at the full impact that violence has within a healthcare organization. And that when leaders then prioritize and fund safety initiatives, because they see that full picture that it has on employee satisfaction, both their perceived and actual safety, the potential impact to quality of patient care, as well as a financial impact. When they look at all of those things together, I think they realize that the cost of inaction is starting to outweigh the cost of, well, we hope things just get better. We also think that a shift in mindset is really needed to help kind of gain that clarity and gain that understanding, so that, as we talked about the CENTEGIX solutions, but a layered, comprehensive safety strategy, not just a plan on paper, but a strategy that everyone knows how to execute on and within, is really important versus siloed or kind of standalone solutions that are put in place to just solve one problem at a time.
So looking back to last year's report, duress alerts peaked on certain days of the week. Last year it was Fridays, Saturdays, and Wednesdays. This year, the alerts, they kind of leveled out across all 7 days, with a slight dip on Sundays and Mondays. What can we take away from that trend?
We were a little surprised to see such a change, but what I think that shows us is that every day there's risk involved in the healthcare setting when providing care around violence. So when we saw that leveled out, really our message is plan accordingly, plan to stay on top of the data, continuously being analytical around what's happening within your organization, and know where you need to address things, because it could be any day, any time of the day that things are happening.
The data also shows a 300% spike in duress alerts between 8:30 a.m. And 12:15 p.m. What kind of, I guess, is the reaction to that, and what can practices take away from that spike? Are there specific clinical workflows that tend to cluster in that window that could leave practice staff or physicians more vulnerable to violence?
There's always a lot happening during the day in a care setting, but during that time period, particularly, there is a lot going on. Morning rounds, when you think about visitors starting to enter in the facility as well, planning for discharge for that day. Again, a lot of activity and a lot of emotions of whether or not you stay or go from the hospital that day. Lunch coverage, things happen during that time, other shift changes. So there's a lot going on that change, that interruption of maybe what you were expecting can really trigger an aggressive behavior from patients or family members or the like. So there's a lot going on during that time frame that people have to be maybe a little more flexible around, and sometimes that can be hard to do.
90% of alerts involve an individual staff member needing support rather than, a building-wide or a campus-wide escalation. What's the most effective way for practices to structure their internal response? I mean, who should be alerted, how fast, and kind of through what channels?
Mhm. Well, what we see the most effective, particularly in our healthcare setting, is that stat is true across the entire customer base at CENTEGIX, wherever we are deployed. But maintaining being immediate. So again, that alert is immediately delivered to those that need to respond to offer aid, and that it maintains it being a discrete notification element. We find that really goes hand in hand with de-escalation training and other tools and resources that are provided to healthcare workers to maintain a calm working environment and also protect themselves. So then again, being immediate, discreet, and then when we look at the responders that come, it can go everywhere from a unit leader or leaders that are on that floor in that facility to security staff, and then all the way to local law enforcement if there's a standalone clinic, as an example, that doesn't have other leadership or security maybe on site at the time, and their first line of defense is local law enforcement. So what we really focus in on is, like organizations should do, understand what's happening within their four walls, what resources they have available to them, and then customize and align our alert delivery to the right responders for that organization, and in particular, that specific location itself. So it can be really unique. And while we have best practices, again, we meet every organization where they are and make sure that we do deliver that quick aid as soon as possible.
With nearly half of the duress alerts tied to certain aggressive behavior, what types of situations are most often escalating in routine care settings, according to the report?
So we see that encounters often happen not only in patient rooms but in hallways, right? So away from that patient care setting itself, between staff and patients and family members as well. And we also unfortunately see um, as tensions grow that there are also altercations between staff themselves. I mean, I think we've seen that from both COVID and beyond. Just the tension and kind of the the air in care settings is a bit different. Expectations are different. Allowance for behavior is different. And so again, we see that happening in a variety of kind of different relationships and things happening in all different places.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, a quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
Behavioral incidents are most commonly triggered in hallways, like you mentioned, or exam rooms, at nurses' stations. Is there a way that practices could redesign or better protect those vulnerable areas?
Well, one of the things that you're thinking about minimizing isolation is obvious, but it can be difficult to accomplish when you think about how care settings are constructed. And so that's really why that accelerated response that we enable when support is needed is critical. And we focus that on as being one of our most crucial elements. But it's also important to think about when we initiate the alerts, like through our system itself. That's why that exact location information is really important as well. So that if someone is alone or is in an isolated area, you know exactly where they are without having to have eyes on them first. You can go directly there.
In terms of that safety technology, the report notes a growing resistance to real-time location system-based safety tools that continuously track staff where they are throughout a building or a campus. Based on what you're seeing, how do privacy concerns affect the adoption of that kind of technology in healthcare?
Mhm. And I think, healthcare workers, the trained professionals, they don't want to be tracked. We've seen a lot of that voice from our own users. Nursing unions across the country have also vocalized this strongly that you don't want to be in a situation where a solution is provided to aid a worker, but they don't want to wear it because they don't want to be tracked because they are unsure if that will be used in a punitive way against them in some other manner. So when you stay focused on safety being the forefront of your solution, and for us that means we're only tracking the badge and the badge wearer when an alert is initiated and when that help is needed. You can see the rise in adoption and appreciation of the tool investment itself because it's seen truly as a solution designed to provide a safer culture within the organization and a speedy response when help is needed, rather than being something that is again seen as punitive and tracked around other items that are not centered in that focus on safety and keeping them safe in their work environment.
Sure. The report also shows that preventing even a small amount of turnover can save practices significant amount of money, and obviously that turnover it comes from that workplace violence, as we've talked about. What numbers should
Mhm.
practices look at in terms of ROI to decide whether an investment into different safety technology or some other kind of safety or violence prevention is worth it?
We spent quite a bit of time in 2025 trying to quantify that for our customers and for ourselves so that we understood the value that our solution delivers. And so we have a new ROI calculator and report where we examine just that. What are the average costs per incident by estimating the work loss costs, labor costs for backup staffing that's sometimes needed, repair of damaged infrastructure if that's the case as well, but also certainly looking at retention and recruitment cost, and when there is an incident involved, workers' compensation claims and other medical expenses. So we really looked at all these different elements that have a true cost that can be identified with them to help organizations take a look at the real cost, the dollars and cents cost of again, less or no action taken around protecting and keeping their staff safe. So again, we put that all in a calculator that we have looked at what does it normally take to replace a nurse as an example. It's over $60,000 a year just or $60,000 to replace one single nurse. And as you look at specialties and physicians, that number is exponentially grows. We looked at average workers' comp claims and et cetera and things like that to help guide organizations to do that calculation themselves to see what that impact really is. We also consider turnover, right? And again, those costs associated with not just the retention of those, but all the training and all the time spent of recurring elements that have to happen to get someone up to speed to provide quality of care within an organization. And in some organizations, there's also an element of taking a hard look at insurance costs. There might be some ability to impact their insurance costs when they are able to reduce the amount of incidents that happen within the organization. So there's a lot of different levers to pull when you also stay focused on safety of the employees, safety of your patients, the quality of care, but then look at that financial impact. It can really be eye-opening.
Great. Is there anything more on the data that we might have missed or glossed over?
I don't think anything that we missed, but maybe if I had to leave us with three themes as we think about 2026, is that as folks are looking at evaluating their safety planning, the tools and the investments that they've made to protect their staff and to provide quality care, is to think about three things. One is that they need to have a workforce centric approach, right? That safety initiatives really need to be aligned with their core business goals, like things like retention and profitability. We talked about that a little bit, but make sure it's also a solution that's going to be adopted. Again, we talked about the less attractive RTLS options and things like that. So again, an investment is only as good as it's used, right, and the value that's actually delivered. The second one is demand for ROI. Again, we talked about our creation of an ROI calculator and report for use for both prospects and our existing customers. But safety investments, they really need to demonstrate measurable improvements in financial performance and really highlight the cost of inaction to help drive some urgency around decisions and increased policies, procedures, and investments in safety within the organization. And then third, accountability. Really, we've seen, unfortunately, a lot of really high profile incidents happen within the last year in particular. There's pending legislation out there now, moved beyond both at the state level, but at the federal level, things like the SAVE Act, and at the state level, Illinois SB 1435. But they're driving greater accountability for workplace safety and not just having kind of a check the box plan on paper, but really helping hold organizations and communities accountable to take action and to have positive plans in place that are effective and real. Again, not just to check the box on paper. So those are exciting things to see move the trend. And so maybe we'll start to see more of an improvement. I think each year we talk about the consistency of the level of violence happening. And so we really want to be part of making a proactive change to lessening that happening. But when it does happen, to be there for help to be on its way as quick as possible. So hopefully those insights help too.
Absolutely. Andrea Greco, thank you so much for joining me today.
Thank you.
Once again, that was Andrea Greco, the Senior Vice President of Healthcare Safety at CENTEGIX. On behalf of the whole medical economics and physicians practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. And don't forget, Physicians Practice will be hosting Practice Academy's new practice management track on Thursday, March 19th, featuring practical, actionable education for physicians and practice administrators. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. As always, be sure to check back on Monday and Thursday mornings for the latest conversations with experts sharing strategies, stories, and solutions for your practice. You can find us by searching Off the Chart wherever you get your podcasts. Also, if you'd like the best stories that medical economics and physicians practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Littrell. Medical economics and physicians practice are both members of the MJH Life Sciences family. Thank you.